Dr. Anna Farizah to the stage as the moderator for the next lecture. Hi and good morning, everyone. So thank you for the brief introduction. And for the next session, it is a topic that is quite under discussed, I would say. But we have a close partnership with our anesthetist. And today I'm proud to introduce our consulted pediatric anesthetist of our hospital, UCAM Specialist Children's Hospital, Associate Professor Dr. Rufinah Teo. She obtained her medical degree from Ireland, completed her master's degree here in UKM, and obtained her fellowship in pediatric anesthesia from Melbourne, having obtaining many years of pediatric anesthesia. We have worked together in many cases. Yeah, and I'd like to then welcome our next speaker, Associate Professor Dr. Rufinah Teo, to the stage. Thanks.
Good morning. Thank you, Madam Chair Lady. And I'm very thankful and proud to Professor Goh and her organizing team for inviting me to share the anesthesiologist's perspective in this prestigious pre-congress workshop. I think this is the fourth collaboration to date that I have done personally with Prof. Goh, and very happy to share my experience. And hopefully I will also able to learn from the audience itself. Let's see. As a pediatric anesthesiologist, the journey partnership with the ORL surgeon has been a long journey, and it takes time to really understand and also to learn the language of surgeon, right? So in Malaysia, the pediatric anesthesiology training is very long. It takes about from the day that you graduate as a medical officer and specialist takes up to about 12 years to become a specialized anesthetist. And if you decided to embark on a special interest group, the pediatric population, you go further another 3 years of training. So it takes a long time. And as a junior specialist, if I'm sure some of you deal with adult patient as well, compared with the adult counterpart, the main difference between a pediatric anesthesiologist and the adult anesthesiologist is quite obvious. So when you're operating on an adult patient, you can see your anesthetic colleagues are always, sitting behind the big screen, the surgical screen, and having a cup of tea or scrolling the handphones and all that. But that is also a good sign. It shows that your patient is really doing well. And compared to pediatric anesthesiologists, they are always by the surgeon's side, if you notice, and we will show you again today at the live surgery. So I hope to share with you and highlight some of the anesthetic priorities during airway procedures and to review some pediatric airway challenges from the anesthesiologist's perspective. And also, hopefully, I'll be able to outline some shared airway management strategies with all of you today. And if you ask any adult anesthesiologist, like what Prof. Henry rightly pointed out, it's all based on this physiology, the general principle, the big difference between the airway of the adult and also the pediatric population. And this is from the Hagen-Poiseuille equation on the flow of the oxygenation. So it's actually boiled down to how we want to oxygenate patient, and all the complication flows around this equation. Okay. So in a normal quiet breathing in adult, because the trachea diameter is fairly bigger compared to pediatric, so the flow is actually laminar. Okay, compared to the pediatric airway, where the trachea and the bronchial diameter is really small, and that's where the problem comes from. So now the flow becomes turbulent. And what happens when the flow becomes turbulent? You need a higher driving pressure to maintain the same flow rate of oxygen to the lungs. And this relationship between driving pressure and flow rate is non-linear when the breathing is obstructed. That means breathing, you've got a turbulent flow. And infants and children with stridor and upper airway obstruction will have significant narrowing of the upper airway. So what does that implicates to the anesthesiologist? So when we have infant with upper airway obstruction, what happens is the flow becomes turbulent. We need a higher driving pressure to give the same amount of oxygen to the lungs. And what we do, we will dial up the oxygen flow rate, and we will close the valve, give a tight fitting mask, and then bag the patient as hard as we can. So what will happen then? All the air will not only go to the trachea and to the lungs, part of the flow or part of the oxygen will also go into the stomach. And in a small babies, when we inflate the stomach, the diaphragm becomes splintered and patient will get desaturated. And the cycle actually goes viciously. They come and go. And unless you address the problem immediately, otherwise the whole thing is going to be into disaster, right? So the technique must take into account of the severe narrowing of the airway. That means we will have difficult ventilation. That means the end-tidal CO2 will accumulate and patient will desaturate fast. Secondly, there will also a risk of difficult endotracheal intubation if there are no proper planning. And therefore, in small children, they go into rapid desaturations. So this is all are not favored by the adult anesthetists. It takes a lot of courage and a lot of training with the ORL counterpart to really come up with a formula and also a good plan before we inducing our patient. So to us, spontaneous respiration throughout procedure is recommended. And during teaching, we always abide to this principle for an anesthetist. If we fail to plan, meaning we are generally planning to fail already. And there must be a agreed plan between surgeon and anesthetist. There are a few things to consider. Number one, there must be a continuous oxygenation throughout the procedure. And the anesthetist must provide a good plane of anesthesia for the surgeon to play around the surgical field. And we as anesthetists also, we must understand that there's a need for surgical access. So all these three components must come together when we do an airway procedure. So the basic principle applies: continuous oxygenation, anesthesia, good plane of anesthesia, surgical access. And with preoperative, sometimes we do serve some pre-medications to just reduce the secretion. Here in our institution, we give an IV glycopyrrolate of 5 to 10 microgram per kg, and fasting guides to follow your own institution. So for us, we follow the 246 guideline, 2 hours prior for clear fluids and 6 hours of fasting before procedure. So in any airway procedure, how do we maintain oxygenation? So the primary aim for an anesthesiologist is to give oxygen throughout the procedure. So there are few terms that we use, and they are basically mean the same thing. So we have pre-oxygenation. Pre-oxygenation, essentially, we give 100% oxygen concentration before the procedure or before they go to sleep. This is challenging and sometimes most of the time does not apply to children, and especially if they are already in very much distress. But it is very essential to extend the safe apnea time. I think Prof. Mike Retter mentioned earlier on that the safe apnea time essentially is the time that is needed for a normal breathing child to desaturate up to 90%. So we take the 90% cutoff point because after that on, the child will desaturate rapidly and cardiovascular instability will ensue. But a lot of time you will notice the younger they are, we will tend to cut short the cutoff time or cut off saturation to 93 because after then the desaturation is really rapid. And we have this term called per-oxygenation, where continuous administration of oxygen during period of apnea or spontaneous respiration. A good example would be a ventilating bronchoscope with a side port for us to deliver oxygenation. And with regards to apneic oxygenation, this is a continuous flow of passive oxygen to create a reservoir which passively diffuse to alveoli. The techniques to improve oxygen delivery, mainly there are two. The first one, we have few options of the interface that we use. A simpler one will be a nasal cannula or a oral pharyngeal airway inserted into the nostril. And to there, we can actually connect to our circuit and give a passive oxygen to the patient. The other second application is to use the oxygen flow rate. We can either give a low flow rate of oxygen of 0.2 and 1 liter per kg per minute, just like the OPA or nasal cannula, or we can give a higher flow, a humidified high flow to the patient, 2 liters, up to 2 liters per kg per minute. So this is where the Thrive, OptiFlow, some of us or some of you may have seen used by the anesthetists. So that's about the oxygen part. What about the maintenance of anesthesia? A good plane of anesthesia basically involves two things. We either put the patient to sleep with volatile anesthetic agent. We call it inhalational induction. So this is more common in children, especially they don't come in with an IV cannula, and maintains with volatile agent. This is rarely done nowadays because we have this technique called total intravenous anesthesia, where we use combination of drugs without the volatile agent to ensure that the patient is asleep throughout procedure. The normal TIVA setup, if you see nowadays, a lot of these tower pumps is being used by your anesthetic colleague. And this is essentially made up of two drugs component, the propofol or Dripivan, if you like it. It's a hypnotic that we use, and also a high potency opioids remifentanil infusion with a depth of anesthesia monitor. So how does TIVA work? TIVA uses a special pump, which we call a target control infusion pump. And this pump relies on pharmacokinetic models where they pre-calculated how the drugs are move around in the body compartments. So generally, the newer the model, the high end of the compartment models are being used. And this is to achieve a targeted concentration. So usually we will have an organ and plasma concentration or an organ concentration to achieve a anesthesia plane that we want. The advantage of TIVA is both drugs actually is a potent upper airway reflex suppressants, and nowadays we can intubate without even muscle paralyze our children. The only side effects is the hypotension and bradycardia. These are not really suitable for patients with a severe congenital heart problem, and this needs to be discussed with your anesthesiologist. So when we give all these target infusion, we think what we give is what we wanted to achieve, or we assume that the machine will give the target that we want. But how do we ensure that the patient is really asleep? So we have this depth of anesthesia monitoring. Essentially, it is a process EEG. If you noticed, nowadays we put a lot of stickers at the frontal cortex. So this is a simplified process EEG that is made easy for us anesthesiologists. They only come up with a number that you need to target on. So this one says 47. So what are the anesthesia plane that we want to target? So in a deep plane of anesthesia, general anesthesia, we will aim for 40 to 60 for a more stimulating procedure. For example, when you suspend the larynx, it is a very, very stimulating part of the surgery. So we will tend to dial up our anesthetics. Nasal endoscopy or sleep endoscopy scope, they are generally painless, and we can safely maintain the anesthesia plane at about 60 to 70 beats. Airway topicalization in our fraternity, it is a very well established study. So it is has been shown to actually reduce the cough reflex, and there are a few ways to do it. We have our own way to do it, and we generally in my institution, we use lignocaine, 2%. Our lignocaine come in 2% concentration, and we use up to 3 milligram per kilo. And we will advocate to use the lignocaine with an atomizer to actually increase the speed of onset and to increase the area of coverage of the laryngeal inlet. Now, the complexity of doing a pediatric airway surgery to the anesthesiologist is mainly to maintain a fairly motionless surgical field. For example, when we're doing laryngeal cleft repair, balloon dilatation, and at the same time, we will need to maintain a spontaneously breathing child with a good plane of anesthesia. So the balance is really between deep sedation and general anesthesia. Also, we need to balance out to avoid the child being apneic, because once it's apneic, then we need to assist ventilation. And once we do that, the breathing becomes chaotic. We need to adjust our drugs. That becomes not familiar and difficult for the anesthetist to work around with, right? Back to the tree concept, we always remember oxygenation is the first, provide good plane of anesthesia and surgical access. Now, what happens if the oxygenation part does not go as well? The airway crisis, and when you have rapid desaturation. The aim of us as anesthesiologists is always maintain oxygenation. To us, it is okay if we are unable to intubate the child and provide oxygen, but we must be able to maintain oxygen with at least a whole mask ventilation technique and give a good CPAP. So during laryngospasm, which often more happen in a non-paralyzed, spontaneously breathing child, we really need to deepen the anesthetics. We sometimes do the Larsen maneuver where we hold the Larsen notch just behind the earlobe. Hopefully, it can break the spasm. It doesn't work most of the time. We can give a small dose of IV succinylmetonium, our muscle relaxant, about 1/10 of a usual dose, just to break the spasm. And with succinylmetonium, you always need to remember they tend to cause bradycardia in young children. So we always pre-medicate beforehand with atropine. So many studies published, meta-analysis done to prevent laryngospasm during induction, emergence, and extubation in children. But the clinical comparison is usually hampered by the heterogeneity of the design, too many design, and the definition of laryngospasm is not well defined in literature when the RCTs are done. and a meta-analysis done where the possible preventive effect of IV and topical lidocaine has been established, like I mentioned before. IV magnesium, just weak efficacy, also mainly due to high heterogeneity of the results. Inhaled salbutamol seems to be efficient in young children undergoing tonsillectomy, but not to other type of surgery, and also to older patients. So recently in Malaysia, they did a national audit on anesthetic airway management where they look at all the patients who had airway manipulation, that means intubation or either with ETT, endotracheal tube intubation, or with just supraglottic airway. What we found that the incidence of major airway complication due to intubation is about 1,000, slightly more than 1,000 per every 100,000 cases of general anesthesia. And out of that, about 150 reported with significant desaturation. So that's why recently the society from the European Society of Anesthesiology recommended that the video laryngoscope should be the first hand or as a preferred method for neonatal intubation. So the first choice. Similarly, there is also other big randomized control trial of infants and bigger children where they favor actually the use of video laryngoscope in their first attempt of intubation for anesthesiologists. So video laryngoscope also comes in many brands, many style. What we have here, we used to intubate with direct laryngoscope with Macintosh blade. And nowadays we have all this video to assist us. We have CMAC laryngoscope in our institution with the D blade. So why is it so useful to us, the anesthetists, is that with direct laryngoscope, our view of the larynx is essentially only 15-degree up and down. And to maximize the success of intubation, we actually need to position the head so that the oral and the larynx and the pharyngeal axis are aligned. So this is what we call the sniffing position. Just put a little pillow up there, and this maneuver, this simple maneuver, actually improves the glottic appearance for the anesthesiologist in a direct laryngoscope method. But with video laryngoscope, the area of view actually enhanced to up to 60-degree. And what is the main difference is the eye of the laryngeal inlet is actually at the tip where the camera is placed compared to this direct laryngoscope where we look from the beginning of the blade. So when you have the camera at the tip of the blade, naturally your view of the laryngeal inlet is widened. So therefore, we don't really need to position our patient's head into that sniffing position. So very helpful, and it's a game changer for anesthesiologists. Post-operative care, close observation and early extubation is always recommended. So we always discuss with our fellow surgeon if we are able to extubate on the table or immediate extubation. So it really depends on your institution makeup. If you have a PACU or post-anesthetic care recovery, that would be an ideal place to place your patient. For short ventilation, just for them to wake up from anesthesia and then extubate. And IV dexamethasone is also useful of 2.2 milligram per kilo to reduce post-operative swelling. This is my last slide. So the goal of anesthesia is really to ensure that surgery is painless, it's smooth and safe for the patient. And with that, we also need to remember to always maintain oxygenation regardless of the type of surgery that we do. Thank you very much.
Thank you, Prof, for the enlightening, sweet and short lecture. Yeah, so we have a lot of questions, especially backlog from even from the previous session. So I have to screen a few questions. Yeah, Prof. Okay, so for first question, in spontaneous ventilation and intermittent apnea technique for airway studies, can you just compare difference and state which is preferred?
Which
This
to
is like
which?
another lecture. In spontaneous ventilation and intermittent apnea technique for airway studies, can you compare the differences and state which is preferred?
From the point of anesthesiologists, we always follow what the surgeon prefer to do. So if the field of the surgical field needs the vocal cord to be still, and we will need to ensure that the plane of anesthesia is actually deep enough for them not to breathe so much. That means they kind of like have their own spontaneous, but what we do is just with assist ventilation. Yeah. So it's really depends on the surgeon need of the operation field.
Okay, I'll just take one more question, yeah? Can we generally say muscle relaxant is not used for airway cases in pediatrics, but we use TIBA instead, TIBA?
From anesthetist point of view, the only indication where muscle relaxant is contraindicated is when we use neuromuscular monitoring. But otherwise, we can always avoid muscle relaxant in our surgery. We can even nowadays intubate a patient without muscle relaxant, just purely using propofol and remifentanil. Yeah. But you really need to have a good team and also an experienced anesthetist to do that. So please discuss. There is no right or wrong. And sometimes the anesthesiologist choose to paralyze patient is because they want to enhance or increase the success rate of intubation. Yeah. So really depends on situation. Thank you.
Right, so that would conclude our third session for today. Thank you, Prof. Okay, so let's give a warm applause. So I'd like to welcome back our MC for today, the stage.